So good morning, everybody. Am I working? Oh, hold on there now.
Just hold. You need to kind of hold it.
Good morning, everybody. Thanks very much for asking me to speak today. I'm absolutely delighted to be here, mainly because I've just done a talk downstairs, and that was much longer, and I've got that out of the way, so all good. Also, my children told me today they thought I was going to a wedding because they haven't seen me in anything but a tracksuit for the last 3 years, so shoes on. So I suppose a lot of you will know a little bit about thrombosis. You know, your experiences will be very different to mine, and I work in the sort of the rare end of the spectrum. So today I'm just going to tell you a little bit about what I do and where I plug into the whole VTE journey, because it is a journey, and even though I'm sort of working on the sort of the Siberia end of it, it's very important that you do know what goes on. So without further ado, okay, so these are the Spice Boys of pulmonary hypertension. This is Professor Sean Gain, who's an international expert in pulmonary hypertension, and the much, much younger Dr. Brian McCullough. This photograph was taken quite a long time ago. So we've been around since about 2003. We are the National Unit for Pulmonary Hypertension. We like to call ourselves that, makes us sound important. When you're a rare disease, you do what you can. And last year we got experts, or we got status as part of the ERN, which is a European reference network, which really gives access to a wide band of knowledge across Europe and sort of pools resources in terms of information and data collection. So we're a really unusual thing. I like to describe myself as a jack of all trades and a master of none. I was a chest pain nurse in Guy's and Tommy's many years ago and in the Mater, and now I work for a rare disease. I know a little bit about lots of things, and I'm not really an expert in any one thing anymore. And the beauty of that is we work with lots of people all around the country, and it's absolutely great. I have friends in so many places. All my aunts and uncles are always ringing me up looking for me to get them in somewhere. So cardiologists, haematologists, radiologists, transplant team, pharmacists, exercise and physiologists, and many, many more people. Many patient groups as well, which are all often very important when you work for a rare disease. There must be an easier way of putting this forward. Hold on. So, what do we do? So, pulmonary hypertension itself is a rare disease. I hung my hat on that for many years until I discovered last year the ERS decided that we weren't a rare disease, that 1% of the population had it and 10% over 65. But chronic thromboembolic disease, which is what I'm about to discuss today, if you look at the little people on the bottom there, you'll see it is a rare disease, because the presence of those little people deals with incidence. So the incidence of chronic thromboembolic pulmonary hypertension in people that have had a PE is probably around 2.6%. So it's not unimportant, but still not as frequent as other things. So CTEPH, where does the journey begin? Probably about 75% of patients that we see have had a prior PE. So it begins somewhere. So most of us would be familiar with DVT. And so DVT obviously usually starts in the legs. It then proceeds, something happens to cause that clot to break off. It can travel to the heart, and this is just an echo, an ultrasound representation of what it looks like as it going through the heart. And we're very clever as human beings. We have many systems that are in place to try and filter clot so that it doesn't go anywhere it shouldn't go. And so the lungs are really designed as a filtration system and should prevent clot from going anywhere else. But sometimes that doesn't work. And so if you see the next phase on that slide is an acute pulmonary embolism. So it looks different, it's red, it's clot. And if you ask the haematologist, they would tell you that there's lots of fibrin in there. And then if you look at the next slide, you'll see what I look after, which is chronic thromboembolic disease. And so that looks very different to PE. And it is very different to PE. So there are obviously some people where when you have a PE, you don't naturally get rid of that clot. They sort of think about 10 to 21 days, the clot should be gone with conventional therapy. But for some reason, some of us don't do that. And so the results can be catastrophic, especially if the condition is not identified quickly. So it's all about pressure, in the words of the great David Bowie. What happens when you develop an obstruction that becomes hard in the vessels, that doesn't dissolve over time? So what that does is the right side of the heart is passive. So really, blood drops into it, it goes onto the lungs, it picks up oxygen, and it goes around to that great big juggernaut, the left ventricle, to be pumped around the body. Now, when you have a clot in your lung that becomes hard and turns into a scar, that process is interrupted. And the right side is suddenly forced to work very hard indeed. So it becomes muscularized. It turns into a pump. The heart beats faster to try and force blood through that, past that obstruction. And that can lead to many problems. So you can have a pulmonary embolism, you can develop a scar, you get the high pressure, and then you can get heart failure. Now, heart failure is a dreadful term. I mean, if you said something was failing, you'd be thinking your number's up. But heart failure really is dysfunction. And so that right side of the heart doesn't work properly after time. Initially it works very well, but after a while it starts to fail. And so blood starts to pool in the extremities, sometimes around the abdomen, and in lots of other places. And left unchecked, that can have a very catastrophic outcome. So it's very important that people in that 2.6% group are identified and sent to the right place. So does everyone get CTEPH? Well, obviously not. So if you're breathless and you've had a PE, do you have CTEPH? No. So most of the time, I think it's generally well appreciated that we love new terms in medicine and we cannot call a spade a spade. So we've got lots of new terms that I'll just show you floating around there. Don't worry about this too much. But long terms really for something that means obstruction. So the obstruction can have consequence. And so consequence of the obstruction in CTEPH is obviously that's where I'm best placed. So when the clot doesn't dissolve over time, you develop CTEPH or CTED. Now it's called CTEPD. I cannot get that out of my mouth, so CTED is where it's going to be. So CTED is when you have a block, but maybe you have no pressure. CTEPH is where you have a blockage that's living there now, but it's causing an increase in pressure within the heart and the system. So who does that occur in? Well, there's definitely some people who are more prone to it than others. So you can have risk factors. For example, everybody who has a PE doesn't have these things, but some of them may. So when you're seen back, if you have an acute PE, when you're seen back, as we hope now lots of people are in a clinic, after 3 months, someone should be looking at you with a magnifying glass to see if any of these things are present. Now, about 50% of PE patients have a syndrome, we think, afterwards called, we're calling it post-PE syndrome. We love a term. So within that group, some people will be breathless just because the trauma of having, if someone told me I had a PE tomorrow, I would be under pressure, I would feel anxious, and it would upset me. And so that can change how you behave. You can become unfit. You might not do the things that you love. And one of the questions I ask people first when I see them is, when did you last feel well? And what were you doing? And what sort of exercise did you used to do? So these things are very important. It doesn't mean that you have CTEPH or CTED. But it can mean that you're just affected by the pulmonary embolism. But there are risk factors where you may think that that person, when they present back to you at 3 months, who's breathless, needs to have a closer look. And so we often do something called a VQ scan. I know it's quite confusing, but I've learned over time that this is one of the tests. This is my friend. I can look at this and I can understand what's going on. So the VQ scan is a very good scan for patients that have had a clot to see if it's become a chronic thing. And so lots of the time what happens next is they come into, there I am, jack of all trades, they come into our clinic. And so the first thing we do is we educate patients. We say, look, lots of people feel breathless. You've been to to see your doctor now, and he's a little bit concerned, or she, that your breathlessness might be because some of that clot's hung around. So don't worry. What we're going to do now is we're going to try and find out whether that is the case. And lots of the heavy lifting is already done by my colleagues in VTE. So we have a really good system at play, and around the country, and you'll hear from others today about the good work that's been done to make sure that people, when they have a PE, are picked up early and sent to the right place. So a lot of what we do in the clinics is around the things that I've discussed already. The most important thing is to understand that CTEPH is a rare undiagnosed condition, and that perfusion defects, which are the things that we see when we do imaging, are often common after a PE, but they may have no relevance. They may just become part of you, because we can exist. Some people are born with one lung. How do they get by? So until you lose a significant portion of the functioning apparatus within the lungs, you don't really get symptoms. So the body is very clever at masking things. We've no real evidence as well to suggest that identifying people who have a block with no pressure are actually people that we should be treating. But we do know that if they're very symptomatic, we had a guy and his goal in life was to swim the English Channel. And so it was very important to him that he had a high level of fitness. Now, him on a bad day was me on a good day. This guy was very fit. I would have been happy just to walk along behind him. But, you know, you have to understand what makes people tick. It's not about the guidelines. It's not about the information, the medical information. Sometimes it's about understanding what makes you tick and what's important to you, and trying to find out what level of exercise you want to be doing and what you want for yourself. So when we see people routinely, the VQ scan, as I said, is very important. So we have like diagnostic strategies where we put people through a variety of pathways to try and get some information. I won't focus on that too much. This is my lovely test that I was talking about earlier. You can see here, one of them is about perfusion. The top is about perfusion and the bottom is about ventilation. So ventilation really relates to how well the lungs are aerated. Perfusion is the blood supply. So the blood supply is what carries oxygen around your body. So if there's an impairment to that, if it's not working properly, if a large area is taken out, I mean, to the untrained eye, you can see the little chunky bits there, as I like to call them, on the right-hand side up top. There's bits missing. So there's obviously areas there that aren't working properly, and this is what we would see. If you have this, if you don't have this, you don't have CTEPH. So that's one thing to take away. And so, but you can have this and you can have CTED. So you have no pressure, but you have what we call chronic thromboembolic pulmonary disease. And so in these kind of patients, they're breathless when they try and do something, but they're not breathless otherwise. So we might decide to do a special test called a CPET. Now, this comes with a huge report that you'd need an immense size IQ to understand. You might be able to help us with that later, but I certainly can't. All I want to know, is it positive or is it negative? Because when you have an area of lung that's essentially dead, when you take a breath in, you have what we like to call dead space. So you have like all this oxygen coming in, but it's doing nothing. It's not going anywhere. It's not being carried anyplace. So the CPET is a useful way at looking at people and trying to decide, even though they're not under pressure, as Mr. Bowie says, they may have symptoms that require us to act. And again, that goes back to understanding what makes you tick. So we have all these little strategies for looking at patients. Most of them are for CTEPH, the one with the pressure, because the high pressure is what damages the heart. And so those patients over a long period of time are at risk of an untimely end, unfortunately, and some of them will eventually go to lung transplant. But we have other strategies. We send people to the UK. We have a very well established strategy of sending people to Papworth. They have done about 4,000 cases of this type of surgery over the last 25 years. And you know, if I'm having this kind of surgery, I want a guy who's done 80, not someone who's done 8. So you know, it's a very good system that they have, and they've served the Irish healthcare system very well over the years. So who goes where? So you can have a block in a big vessel, you can have a block in an intermediate sized vessel, or you can have a block towards the end. And the strategy of how we deal with that can be surgery, we can do angioplasty, or we can use medicines, or we can use a combination of all three. But the only one that provides an immediate cure, almost, is surgery. So when you have that high pressure, I'll actually just show you what it looks like. I'm not sure if this will work, but I'll try. This is an operation.
This is another view of the right arterial tree and the endarterectomy performed.
Look away if you're squeamish. So I once heard the surgeon who does the most of this describe this as removing the snot from a nose. So yes, I have to say that I was quite surprised, but he's not wrong. And you know, these are really delicate blood vessels. I mean, if you take the lungs out, it's almost like cobwebs almost. They collapse the minute they're not aerated. So the idea that a surgeon can go in and remove this hard plaque from within the pulmonary arteries is amazing to me. And these patients, the pressures almost normalise immediately. But the problem is that because there's a delay, that they get downstream damage in the smaller vessels, and they get a disease that's almost like another form of pulmonary hypertension that I look after. So time is key. And then again, if you look at it down here again, you can see the acute PE, which is blood clot rich, is very different than the, pardon me, snot that he removed from the vessel. So this is angioplasty. Everybody knows about angioplasty. You go into a small vessel, you blow up a balloon. It's a bit of a blunt instrument, but it definitely works. And we send people to Papworth in the UK. They go and they have about 4 procedures, usually spaced a few weeks apart. And there is problems with this. There can be injury from the procedure, but now we pre-treat these patients with medication, and their survival rates are about 90% at 3 years, which is very similar to surgery. So this is also a good procedure and seems to work better for blockages that have gone further downstream into the smaller vessels. We've lots of drugs that we use for lowering the pressure, so that when they go in to do these kind of procedures, it's easier. Now the surgeons don't like that, but we have to use these drugs as a bridge, because if you want surgery in the UK or you need it, it doesn't happen overnight. There's a whole process of things that have to be put in place, which takes on average probably about 6 months. So Papworth in the UK, it's in Cambridge at the moment, that they've moved recently, and obviously they're the experts in this, and we have a very good relationship with them. So the first thing we do is prepare a file, and Deirdre Clerk in here, she is like a detective. If you have information in a hospital around the country, she will find it, and she will get it, and she will put it into that file for you. And then we wait, we patiently wait. Nobody knows what this is. Does anybody know what that is? We wait for the papal smoke. We wait for them to tell us that, yes, you can go, yes. And so we tell the patient, so that in itself takes a while. And then using the treatment abroad scheme, which is still viable to us, even post-Brexit, we are able to facilitate sending people to the UK for the surgery. And obviously we bridge them with the medication in the meantime. So yep, that all seems to work quite well. We've been doing it for probably about 18 years now. And so we do a lot of other things. I won't go into all this with you, but you know, we're very much about quality of life and making sure that people, you know, if you're not mentally able for the challenges ahead, that's very important to us. So you know, we look at things from a very rounded perspective, and we've just applied for funding actually for our own psychologist. So hopefully that will be in place soon. And then there's some take-home messages. So a lot of this is just about statistics, but really I think the important thing to know is that most people that have a PE, under the good guidance of your local clinicians, will recover and will do well. So what I'm talking about today is an unusual consequence of pulmonary embolism, but it's obviously very important that people know there is somewhere to go. Thank you. This is where I'd love to be.
Visit thrombosis.ie. Spot the signs, save a life.